11th. Since that time, upwards of 3 million service members have been deployed on more than 5.4 million deployments. 17% of the service members that have volunteered to defend this country in what has become the longest war in this nation's history are women. They are mothers, daughters, sisters, soldiers, airmen, sailors, and Marines, and those that were able to return home from the battlefield deserve the same access to timely, high-quality health care as their male counterparts. That is why during the 116th Congress, the Health Subcommittee's key focus has been ensuring equitable access to high-quality health care for our nation's heroes. As chair of the Women's Veterans Task Force, I'm proud to lead 78 members of Congress in identifying gaps and opportunities to achieve equity and access to health care benefits, economic opportunities, and other resources for women veterans. I'm pleased that today's hearing includes 12 bills that will improve equity for the delivery of health care for women who have served in our nation's armed forces. Also, this month is Suicide Prevention Month, and it is critical that we address the gender-specific mental health needs of women veterans. Women veterans are nearly twice as likely to die by suicide than women who have never served in the military. Experiencing military sexual trauma, isolation, and intimate partner violence increases the risk of suicide in women veterans. Suicide is preventable, and several of the bills presented at today's hearing provide additional resources to programs and services known to decrease the risk of suicide in women veterans. My bill, H.R. 2798, the Building Supportive Networks for Women Veterans Act, provides reintegration counseling for women veterans in retreat settings. H.R. 3867, the Violence Against Women Veterans Act, introduced by Ms. Velasquez, improves programs and services for veterans who are survivors of intimate partner violence and sexual assault. Mr. Brindisi's bill, H.R. 2972, improves resources for the Women Veterans Call Center and VA website so that women veterans can easily obtain information about accessing benefits and health care. Research shows that these resources and knowledge that those resources exist significantly reduce the risk of suicide in women veterans. Ranking Member Dunn, I understand from yesterday's Member Day that Mr. Bergman has also introduced a bill related to suicide prevention, and I'd like to reiterate Chairman Takano's commitment to work alongside you and Ranking Member Rowe to support VA's ability to connect veterans to the upwards of 45,000 community-based organizations that seek to serve them. Women veterans are the fastest growing demographic in the veteran population, and it is clear that VA facilities must be built, retrofitted, and staffed in accordance with that pace of growth. H.R. 3636, the Caring for Women Veterans Act, introduced by Ms. Underwood, H.R. 3036, the Breaking Barriers for Women Veterans Act, introduced by Mr. Rose, H.R. 4096, the Improving Oversight of Women Veterans Care Act of 2019, and my bill, H.R. 3223, the Women Veterans Equal Access to Quality Care Act, all ensure that VA is providing sufficient staff, training, building and retrofitting facilities, and maintaining environment of care standards wherever women veterans receive taxpayer-funded care, whether at a VA facility or a community care provider. It is imperative that we eliminate all cultural and physical barriers to women veterans' health care. Mr. Pappas' bill, H.R. 2681, ensures VA is equipped to provide women veterans with life-transforming prosthetics that are specifically for their needs. Over the past decade, VA conducted 2 studies to identify barriers to care for women veterans. The most recent study completed nearly 5 years ago, enabled VA to identify necessary changes to improve services for women veterans. More still must be done. And Mr. Cunningham's bill, H.R. 2982, renews the authorization for the Barriers to Care study to enable VA to best serve women veterans by 2030 and beyond. In the last 20 years, we have seen a significant shift in the demographics of the veteran population. Not only is the woman veteran population growing rapidly, but women veterans are on average 15 years younger than male veterans and more likely to be of reproductive age. That is why members of the Women Veterans Task Force introduced 3 bills to improve reproductive health care access for women veterans. My bill, H.R. 3798, Equal Access to Contraception for Veterans Act, eliminates copayments for prescription contraceptives so that women veterans have the same access to birth control as during their service. For veterans who choose to become mothers, 2 bills will give veterans peace of mind in the earliest days of their newborns' lives. H.R. 2645, the Newborn Care Improvement Act, introduced by Ms. Lee, doubles the number of days of newborn health care coverage for children of veterans. Mr. Allred's bill, H.R. 2752, the VA Newborn Emergency Treatment Act, further expands coverage for newborns when medically necessary and streamlines the billing process so that veterans are not unnecessarily burdened with debt after the birth of a child. In addition to today's legislation focused on women veterans, we are also considering a number of bipartisan measures that have been introduced by my Republican colleagues. Last Congress, I was honored to join a number of members of this committee to co-sponsor the Long-Term Care Veterans Choice Act introduced by Congressman Clay Higgins. This measure is a first step towards right-sizing VA's long-term care options by offering veterans more opportunity to age at home. As women are generally expected to live nearly 5 years longer than men, ensuring VA is prepared to care for its aging population is important to women veterans and the community at large. In addition, the legislation introduced by Congresswoman Stefanik, H.R. 2816, the Vietnam-era Veterans Hepatitis C Testing Enhancement Act of 2019, would allow VA to partner with veteran service organizations to offer hepatitis C testing at outreach events is an important step towards ensuring VA is properly leveraging its existing partnerships to reach veterans where they are. As chair of this health subcommittee, I am truly proud of the work we are doing here today. I'm especially proud of the way we are doing it in a bipartisan manner. In closing, I would like to thank our witnesses for appearing, and I look forward to your testimony. Before I recognize Dr. Dunn for his opening statement, I would like to note that I will not be asking members to waive their opening statements today, as is tradition, so that the members with legislation on today's agenda are afforded the opportunity to issue statements in support. While a few of the members with legislation before us today are not members of this committee, please note that each has been given the opportunity to submit a statement for today's record, as well as the opportunity to deliver remarks in support of their legislation at yesterday's Members' Day before the full committee. With that, I'd like to recognize Ranking Member Dunn for 5 minutes for any opening remarks he may wish to make.
Thank you, Chairwoman Brownlee. After several weeks away from Washington, it's good to be back with you working to serve our nation's veterans. Our agenda this morning is full, and I look forward to our discussion. Before yielding, I would like to say I have 3 areas of regret and a little disappointment here, and that is this is the second legislative hearing that this subcommittee has held in Congress, and both of the agendas of those hearings were set entirely by the majority without any input from the minority, either members or staff. The witness list for this hearing did not include the member panel, which you mentioned just a moment ago. Typically, members who sponsor bills are invited to testify and contribute to our conversations about their bills. I note that the committee members with bills up for consideration today, committee members with bills up today, have been allowed to sit on the dais and testify on their bills. And while most of the Democrat bills are sponsored by the majority members, only one of the Republican bills chosen by the majority is sponsored by a committee member. So it's probably unintentional, but it creates a perception of imbalance. By failing to provide the minority an opportunity to provide input about bills to be considered, and further failing to provide sponsors from both parties equal opportunity to advocate for their legislation, I think it runs somewhat counter to the past practices of this subcommittee. The VA and its subcommittees have uniquely been very bipartisan, and I sincerely hope we'll continue to conduct it that way. Finally, had the minority been consulted in advance about the agenda, there is one bill that we would have asked to be included that has not been. That's H.R. 3495, the Improve Well-Being for Veterans Act, which you referenced in your open statement. The Improve Act is bipartisan legislation sponsored by Congressman Bergman and Congresswoman Houlihan. I note for the record that Congressman Bergman is also Lieutenant General Bergman, the highest ranking officer and veteran ever to serve in Congress in the history of our nation. It is supported by many veteran service organizations and by the VA, and most importantly, it addresses what Chairman Takano has stated repeatedly is this committee's single highest priority, preventing veteran suicide. By creating a grant program to support entities that provide and coordinate suicide prevention services for veterans and their families in their local communities. The Improve Act alone would not solve the national suicide crisis that tragically takes the lives of 20 veterans a day. But it could certainly be part of that solution. It would save lives, and it is worthy of this subcommittee's time and attention. When staff was first informed of today's hearing, after the majority had already set the agenda, and informed the VA of the hearing, our staff requested to add the Improve Act to the agenda, and that request by staff was denied. Letters were subsequently sent to Chairman Takano by Secretary Wilkie, and followed by Ranking Member Rowe requesting the Improve Act be included. Chairwoman Brownlee, I certainly hope that your staff provided you copies of those letters, and to my knowledge, we've had no response on those. September is National Suicide Prevention Month, and Chairman Takano marked it on September 1st by calling for new solutions and fast actions. One concrete way for this committee to follow that call would be debating the Improve Act without any unnecessary delay. I regret that we're not doing that, but with that, I look forward to today's hearing, and I yield back. Thank you.
Thank you, Dr. Dunn. Appreciate it. And just to follow up on your remarks with regards to Lieutenant General Bergman's bill, I assure you and the committee that our staff and Chairman Takano are prepared to work through that bill to gain bipartisan support, and hopefully that particular bill will come forward to us at another time. So appreciate your comments there. So now I would like to recognize Congressman Rose for 5 minutes for any opening remarks he may wish to make in support of his bill.
Thank you, Chairwoman Brownlee and Ranking Member Dunn, for having this forum to provide due attention to the pending legislation before us. With respect to legislation impacting women veterans before us, let me just say it is beyond clear that the women who served alongside me in Afghanistan, who also served in Iraq, and who have generally put on our nation's uniform in defense of all that we hold dear, they deserve our support and national investment now more than ever. When these heroes come home, they aren't necessarily greeted with a hero's welcome, although they are always thanked for their service. Instead, they face challenges severely disproportionate to their civilian and male counterparts, and it's unacceptable. Studies have shown women veterans have higher rates of interpersonal trauma than male veterans, and this includes military sexual trauma. There's little doubt that this plays a role in higher instances of medical challenges than other groups. And tragically, women who served have a rate of suicide that is nearly double than that of civilian women aged 18 and over. It's Suicide Prevention Month, and I want us to fully appreciate the scope of that. We cannot let this persist, and let me just say that if you thank a female veteran for their service when they come home, but nonetheless do not do anything about the fact that they receive inadequate health care at our VA institutions, then beyond that just being hypocritical in nature, saying thank you for your service is a disgraceful thing to be doing if we're not fixing this. Our female veterans deserve so much better. That's why I'm proud to have introduced H.R. 3036, a critical bipartisan piece of legislation to make sure facilities at the VA are as equipped as possible to serve a growing population of veterans. This bill would ensure funds to support the physical infrastructure of our VA hospitals and clinics for women veterans' care needs. It would require that there is at least one full-time or part-time woman's primary care provider within any given clinic or facility, and would expand the Women Veterans Health Care Mini Residency Program, which further protects against staffing concerns being a barrier to access. And in addition to requiring the VA to produce relevant reports as care is provided, this bill would require the VA to establish a training module for community providers, because as we see time and again through these hearings, these issues do not end within the four walls of the VA. After seeing the VA's testimony to this subcommittee, I'm heartened that the VA supports the intent of many provisions within this bill. And while the VA is working on many of these goals, we must ensure that our women veterans do not fall through the cracks. That's not an option. So again, I urge all my colleagues to support this legislation. I thank many of those who have co-sponsored. And again, Madam Chairwoman, thank you again for the time.
Thank you, Madam Chair. I appreciate it. I'd like to thank you again for, and the ranking member, of course, for allowing me to sit on this subcommittee hearing and allowing me to speak on one of the bills being considered today, my legislation, which is H.R. 2628, the Vet Care Act. Many of my veteran constituents have come to me over the years expressing their desire to add dental care to the VA's medical benefits package. As you know, Madam Chair, the VA currently only provides outpatient dental services to a limited number of the disabled veteran population who have 100% service-connected ratings. And then there are a couple other categories as well, POWs, and again, anything that happened on the battlefield as far as if it's service-connected regarding the mouth area. But some of my, again, some may be eligible. Some veterans may be eligible for the VA dental insurance program, which provides a discounted low-cost insurance plan provided by private insurers. But I believe we can do more to move this issue forward. And I commend you, Madam Chair, for filing your bill as well. I'm very supportive of your bill. Many small studies suggest that regular dental care equates to lower overall health care costs and better health outcomes. One such study, published in the American Journal of Preventive Medicine, conducted by the University of Pennsylvania professor Dr. Marjorie Jeffcoat, found that regular periodontal checkups lead to reduced hospitalizations and overall medical cost savings in care for chronic conditions such as heart disease, cerebrovascular disease, including stroke, and diabetes. And again, I think there are more chronic diseases that are affected as well. In light of these results, I worked directly with Dr. Jeffcoat and Dr. Zach Calorico, who is a constituent of mine from Wesley Chapel, Florida. We worked to develop the parameters and replicate this type of study at the VA by authorizing the Vet Care Act. H.R. 2628, my bill, expands on this research to help determine the potential health benefits to veterans and potential cost savings to the VA associated with periodontal care. The Vet Care Act would require the VA to create a 4-year pilot program to provide dental services to 1,500 veterans diagnosed with type 2 diabetes. Each treated veteran will receive appropriate periodontal evaluation and treatment on an annual basis during the pilot. Throughout and at the conclusion of the pilot, the overall health of the treated veterans will be recorded. These results will be compared to veterans who did not receive treatment to determine if providing veterans with dental care equates to fewer complications of chronic ailments. If so, an analysis can be done to determine if the lower costs of the overall health care due to fewer chronic ailments saves the VA enough money to reallocate funds to provide more veterans with dental care. It makes sense as far as I'm concerned. The data recorded and collected by the VA would also be able to be distributed to the research community for further study. Finally, at the end of the pilot program, the 4-year pilot program, veterans who participated in the program will receive administrative support and information from the VA on how they may continue to obtain dental services and treatments in the community for low to no costs, including information about enrolling in the VA DIP program. Now, I want to thank the nonprofits and the dental associations that offer care to our true heroes as well currently. In this way, we can ensure that we are providing continuity of care for veterans in need of further treatment. To conclude, if we're able to improve the VA healthcare system by providing preventive dental services that lead to fewer complications of chronic ailments, it not only shows that we are looking at the long-term outlook of our veterans' health, but it could also prove to be done in a cost-effective manner. The Vet Care Act is a practical, common-sense way to demonstrate this approach for dental services, replicating already established research in the community. Again, I thank the Chair and I thank the Ranking Member for bringing this bill up for discussion at today's hearing, and I look forward to continuing the conversation further. Thank you, and I yield back, Madam Chair.
Thank you, Mr. Bilirakis, and thank you for your work on this important measure, and I am hopeful that we'll be able to find a path forward on this very, very important issue, and so thank you for bringing this bill forward. Congressman Brindisi, you are now recognized for 5 minutes to deliver any comments you may have in support of your bill, H.R. 2972.
Thank you, Chair Brownlee and Ranking Member Dunn, for the opportunity to speak today about the importance of improving VA services tailored to the needs of women veterans. I'd also like to thank the committee for their continued efforts this year to make VA more accessible and equitable for our women veterans, and for Chairwoman Brownlee for your leadership of the new Women's Veterans Task Force, which I'm proudly a member of. Women veterans are the fastest growing demographic in the veteran community. Women comprise nearly 10% of the veteran population, and that figure is expected to rise to 18% over the next 20 years. As a result, the number of women veterans seeking care at the VA will certainly increase, and VA needs to be ready. However, 75% of women veterans do not use VA health care and face a number of inequalities in a system that simply hasn't adjusted quickly enough to meet their specific needs. That is why I introduced H.R. 2972, which directs the VA Secretary to improve VA's communications regarding services available to women veterans. While VA has begun to offer text messaging as a way to connect the Women's Veterans Call Center, and I commend VA for doing so, my bill would statutorily require VA to include a text messaging capability at the Women's Veterans Call Center. The Women Veterans Call Center is staffed by female VA employees who can provide a link, who can provide and link women veterans to information regarding resources available to them, and requiring text message capabilities at the call center will make it even more accessible. Additionally, this bill would make navigating VA websites easier by creating a central web page where women veterans can access various information regarding the extensive resources available to them within VA. This page would include the locations of each VA medical center and community-based outpatient center, as well as the name and contact information of each women's health coordinator and contact information for staff from the Veterans Benefits Administration and the National Cemetery Administration. This bill would build on efforts by the VA and this committee to ensure all women veterans are aware of the hard-earned resources and benefits available to them and where to turn if they are struggling. I believe this bill is a positive step forward towards making VA more accessible to women veterans, and I urge the committee to support this legislation. I want to thank Chairwoman Brownlee, and I yield back the balance of my time.
Thank you, Mr. Brindisi.
Thank you, Chairwoman Brownlee, for holding today's hearing, and thank you and Dr. Dunn for permitting me to join today's important panel. I appreciate you and Chairman Takano's willingness to focus on and fight for what our women veterans need. Women veterans face a number of unique needs and challenges, from access to clinically appropriate services at VA facilities to mental health care. We need to act now to address their needs because the number of women veterans is going to increase dramatically in the next decade. I'm proud to serve both on Chairwoman Brownlee's Women Veterans Task Force and on the Service Women and Women Veterans Congressional Caucus, founded by my fellow freshman, Congresswoman Houlihan. So I'm thrilled that the committee is moving forward today on my legislation, H.R. 3636, the Caring for Our Women Veterans Act. My bill directs the Secretary of Veterans Affairs to submit an annual report to Congress on gender-specific care available at VA facilities. This includes locations where women veterans can access VA care, the numbers of women's health care centers and women's health providers like OBGYNs, and recommendations for improving those facilities to better serve women veterans. The bill will provide an informed and sustainable roadmap to providing high-quality, accessible care for women veterans. I also want to highlight two critical healthcare issues for women veterans that I've been working on this year. The first is eliminating copays for contraceptives, breast cancer screenings, and other preventative healthcare services for veterans. Right now, civilians and active duty service members don't have to pay these copays, but veterans do. That's unacceptable, and we need to fix it. Chairwoman Brownlee has been a leader on this issue, and I'm looking forward to working with her to close this loophole and eliminate unfair healthcare costs for our veterans. Lastly, I'm proud to be introducing the ACE Veterans Act today with Congressman Connor Lamb. This bill allows women veterans to get a full year's supply of birth control at a time at the VA. My focus is always on data-driven, evidence-based policymaking, and so this bill builds off research showing that a full-year contraception dispensing improves health outcomes for women and saves the VA money. As this committee moves forward on legislation to improve health care for women veterans, I'm excited to work on these proposals and more. Thank you again for holding today's hearing and to our witnesses for being here. I yield back.
This committee and a healthcare professional is really invaluable, so we really appreciate you being part of this and moving this important issue forward. So are there any other members that would like to deliver any opening statements this morning? Hearing none, we will move on to two great panels before us today. I thank each of you for joining us today in what I hope to be a fruitful discussion on these 17 bills. For our first panel, we have Dr. Teresa Boyd, Assistant Deputy Undersecretary for Health for Clinical Operations at the Department of Veteran Affairs. Dr. Boyd is accompanied by Dr. Patricia Hayes, Chief Consultant, Office of Women's Health Services. We're also joined by Dr. David Carroll, Executive Director for the Office of Mental Health and Suicide Prevention at the Department of Veteran Affairs. I now recognize Dr. Boyd for 5 minutes for her opening comments.
Thank you and good morning. Good morning, Ms. Chairman Brownlee, Ranking Member Dunn, and members of the subcommittee. Thank you for inviting us here today to present our views on numerous bills, including those that address the critical needs of women veterans, as well as other important areas. I also want to recognize the veteran service organizations represented on the next panel, as I have seen personally how much they contribute to our work on behalf of veterans and how dedicated they are in our common mission to serve veterans. I do need to thank you for your patience as the submission of my written testimony was delayed. Because I need to keep this statement brief, I cannot address all 17 bills in my oral statement, but they all touch on important topics. Of course, the written testimony covers all the bills in detail, and we are prepared to field questions on them today. I would like to take a moment to briefly discuss a bill that is not on today's hearing. H.R. 3495, the Improve Well-Being for Veterans Act, would help VA build partnerships with community groups who can offer direct help to veterans who are at risk of harming themselves. VA believes this legislation will assist us in reaching the 14 of the 20 veterans dying each day by suicide who are not under VA care at the time of their death. It would fulfill a critical legislative component of the administration's multifaceted program to prevent veteran suicide, and we strongly urge its consideration. We appreciate that so many of the bills today are focused on meeting the special needs of our women veterans. That is a priority of the Secretary and a big focus of attention for VHA. VA supports the following bills, at the very least in principle, relating to the care of women veterans, although for some we do believe there are important technical changes that should be made, or we need to ensure that the initiatives are adequately funded. We support H.R. 2645, which would increase the period that VA is authorized to care for a newborn child. And we also support, in principle, H.R. 2752 regarding transportation of those newborns when medically necessary. For the latter bill, however, there are some significant technical issues that would need to be worked through. H.R. 2798 concerns special retreat programs for women veterans returning from long deployments. VA is enthusiastic about these retreats. We have received very positive feedback from participants who have said they now realize that they are not alone and that they have learned to trust themselves and feel that they are important. The response has been so positive, we would like to expand the scope of the bill for all veterans who are eligible for Vet Center services, as long as we can secure adequate funding to do so. We support H.R. 3798, which aims to further improve veterans' access to contraceptives, although we do have some technical points to offer on this bill. There are other bills concerning women veterans on the agenda that we cannot offer our support today for the reasons explained in detail in my written statement, even though we are fully in line with the goals of the sponsors. In some instances, we believe they are duplicative of existing programs or initiatives, or are inconsistent with clinical practice. For example, on the key importance of making sure our clinical spaces are ideally configured for the needs of women veterans, the subject of H.R. 3036, many of the actions called for in that bill are already being undertaken. And for H.R. 2982, which requires a study of barriers that women veterans encounter in securing care from VA, we have in place an array of initiatives that recognize those barriers and aim to remedy them. Regarding the draft bill that would establish the Office of Women's Health, we believe that the current placement of the Office of Women's Health Services is strategically aligned to interact with all other clinical programs at the national level that provides a conduit for coordination and collaboration where services are similar. For H.R. 4086, we understand why the committee wants to get a formal report on issues of concern to women veterans in the context of care with community providers. However, the data points required for the report would require the modification of contracts with community providers, which, given the extent of care in the community, would be disruptive. We would like to discuss how the committee could exercise oversight in this area by other means. H.R. 3867 is focused on an area of an intensive nationwide concern for veterans and non-veterans alike, the issue of domestic violence and sexual assault. VA is totally in accord with the goal of coordinating in the fullest way possible all VA services across the board for victims of domestic violence and sexual assault. There are other provisions, however, that may be duplicative of current programs or require technical changes. VA is very engaged in this issue, and we would welcome the further discussion with the committee. There are other bills on today's agenda that concern issues not directly tied to the special needs of women veterans, but which also touch on critical subjects. We support H.R. 1527, which would allow VA to pay for long-term care in what are known as our medical foster homes. This option is something we are enthusiastic about, as it will help reduce a barrier to the use of these homes. For some veterans, a more home-like setting has great advantages over traditional nursing home care. We look forward to discussing some of the technical issues identified in our written testimony. H.R. 2628 concerns dental care for veterans. We support the part of the bill regarding administrative support to those providing dental care to veterans separate from VA's authority, although we do have some technical comments. VA does not, however, support Section 3 for several reasons. We are concerned the bill would create disparities in the overall application of dental eligibility by expanding access to these benefits to veterans in participating locations but not elsewhere. We also believe the bill is far too prescriptive in terms of its requirements and that it is unnecessary because the dental literature already strongly supports the cost-effectiveness of preventive dental care. Before I conclude my statement, I know we all want to acknowledge the veterans and service members who were inspired to serve our country in response to the attacks that occurred 18 years ago today on September 11th, 2001. We are eternally grateful to you and all veterans and service members for the many sacrifices you and your families have made in order to preserve our freedom as a nation. Thank you again for inviting us here today. My colleagues and I are prepared to answer any questions you may have.
Thank you, Dr. Boyd, and I now recognize myself for 5 minutes for questions. And the first question that I wanted to ask is regarding Mr. Rose's bill 3036. And in your written testimony, I understand with so many bills that you can't address each one in your opening comments today, and I understand that. But I did read your written testimony, and I thank you for its thoroughness. And you noted that the turnover for women's health providers is 20%. And during the task force, we've been traveling across the country and having lots of visits, both myself and staff making these visits. And we've really learned that the high rate of trauma within the women veteran community that's taking place can cause secondary trauma to the healthcare providers because they're listening to so many traumatic stories. And so staffing shortfalls have made it even more challenging for the providers because if there are less providers, they have more tragic stories to hear. And so I wanted to know really, what the VA is learning. First, making sure that you're doing exit surveys of these providers who are leaving, and what you're learning from these exit surveys to help inform us in terms of how to hold on to our healthcare providers, particularly women healthcare providers and women healthcare providers who are serving our women veterans.
That's a great question, and I do believe that next week there will be another hearing with some subject matter experts with regards to our hiring and our workforce. I will briefly state a few things and then let Dr. Hayes jump in. One thing that we have started to do, and we don't have enough data yet on it, but is to not wait until the exit, to continue to go ahead and do that, but let's get in the habit of asking folks and learning why folks stay, why our providers stay. What keeps them here. With regards to burnout and exhaustion, workload, depersonalization, we pick that up more and more specifically now on our all-employee survey as well. So in a nutshell, we have some tools that we're trying to connect the dots, but I do want to give Dr. Hayes a little bit of time because she has specifics about the women's health providers.
Good morning. You have pointed out some really critical issues for us about the overburdened numbers of women's health primary care providers. In fact, we've been doing a deep dive on their burnout and on their retention issues, talking to them, those that have left, having interviews. What we're finding are a number of factors. One is that the population has grown so fast and we haven't gotten enough help, not enough providers in each site, and that's sort of a topic of a lot of other things we've been talking about, how to build that staff. One of the other factors is that they frequently don't have the appropriate nursing staff. So you can't take care of these women in a clinic without the nursing staff and the other staff such as social work and pharmacy. So the staffing levels in the PACT clinic is one of our targets. And then just the tremendous sense, as you were saying, of the complexity of these patients with trauma histories and also usually several physical comorbidities. These are very complex patients, and it's too much. We need to reduce the panel sizes. What we're doing is attacking all these issues. The Undersecretary and the Principal Deputy have charged me with a women's health modernization called an IPT. We've been meeting approximately 3 times a week since June. We are looking at these in a very deep dive way and coming up with action plans for management that is coming back up to the leadership, we are hoping within the next month or so. So we're going to be informing the field where the problems are, what are the things we know, and try and deal with the issue of hiring more providers. But we'll be getting into that a bit more in this hearing, I imagine, because the primary care provider recruitment issue is beyond women's health as well. It's a problem nationally.
Thank you, Dr. Hazen. This committee and myself will be very interested to see what your deep dive reveals and what some of the solutions and policies moving forward are. So I appreciate that. Well, I only have a few seconds left, so I'll end my questioning, hopefully can get back to it. But, and so I will now yield to Dr. Dunn for 5 minutes for questioning.
Thank you, Chairwoman Brownlee. This first question is for Doctors Boyd and Carroll. Do you have formal views? It's regarding, by the way, the Improved Wellbeing for Veterans Act. That's 3495. Do you have formal views and cost estimates regarding the Improve Act for the VA, and are you able to provide those? Sure. Either, both?
Yeah, good morning, sir. Yes, we do. I know we've prepared them. We will make sure that the department gets them to you if you have not received them.
Yeah, I appreciate that very much. Is it fair to say that you are supportive of that act?
Yes.
And Dr. Boyd?
Absolutely, we strongly support it.
Do you think it could be funded out of existing appropriations without impacting the department's internal mental health or suicide prevention programs?
Yes, a similar proposal was included in the President's FY20 appropriations budget, and so the plan was to fund it out of current appropriations without any impact or jeopardy to
Thank you.
current
You make me feel
programs.
so much more comfortable. I appreciate that. Dr. Boyd, regarding H.R. 1163, do you know how many prospective hires each year are barred from VA employment due to non-compete agreements with other healthcare systems or private practices?
I do not have that information.
Is it something that's actually obtainable? I mean, do you think do
It's
you have a sense of it?
I have anecdotal after being in the field and being a chief of staff. I think it's anecdotal, and I'm not really, I wouldn't put a lot of credence in it. There will be a hearing next week where there will be the workforce HR folks involved, and they may have more, but I doubt at this point that they do.
Yeah, I'd be interested to know that. Certainly in my private practice, we saw those non-competes crop up, even when a doctor was going into the VA, which I was sort of surprised at that. But, you know, people are people, right? Do you know, has your office, General Counsel Office, reviewed this piece of legislation, 1163, and do they have any concerns regarding the potential legal challenges that could arise as a result of this bill impacting existing non-compete agreements?
Yes, sir. There may be an unintended consequence, especially for Section 2. It's possible that the former employee, the employer, may actually litigate.
Yes.
And that is not something that we want. And back to your comment, if I just may, really the VA is not in competition with private sector. And so...
Well, and I perceive that just like you do.
Yes.
But nonetheless, I see these non-compete agreements become stumbling blocks to treatment for veterans and employment of doctors. You have an answer? I mean, your general counsel maybe has an answer.
They do. Well, on that, again, I can just go back to my own experience in the field. I come from the private sector, but then within the VA hiring physicians as a chief of staff. And most of the time, it was the former employer did not follow through on that non-compete. And that was just in my experience.
All right. Well, let's, again, since I'm picking on Dr. Boyd, actually, I'm enjoying your testimony. I'm not picking on you. On 2816, the Hepatitis Testing Enhancement Act, first let me say 100,000 veterans cured of hepatitis C. Never did I think I'd see that in my lifetime. That is such good news. So congratulations. I know you've worked the number down to 25,000. Keep going. How does the VA intend to continue the screening and the awareness on hepatitis C?
So it's been a multifaceted approach. We're down to the more difficult veterans to bring in to test, and to not only test, but if they're positive, to actually treat. We are down to those that are difficult to find, difficult to locate, maybe some of the homeless veterans as well. And so we continue. It's a multifaceted, interdisciplinary approach, not only with the homeless programs, but with our primary care, it's with all of our clinical. We did send out a letter to all veterans that had not been screened within that cohort. And that letter is
There's
in order.
100% screening on time of separation from the military. Am I correct?
Now, that I'm not sure. I would have to find out about that.
I think that's one good way to start the screening, although you can get hepatitis C as a veteran. Well, with that, we're out of time. I appreciate your comments. Thank you, and I yield back, Madam Chair.
Thank you, Dr. Dunn. Congressman Rose, you are now recognized for 5 minutes.
Thank you, Madam Chairwoman. I want to first off give you all an invitation to just speak to the issue of frequency of deployments, as well as the time between deployments, and any effect that you have seen this have on the post-9/11 female veteran population, and any lessons that we could potentially learn as we as a nation conduct warfare in years ahead.
So I will pass that off to Dr. Carroll initially to see his input on that, and then, of course, Dr. Hayes will have more specifics about the female deployments.
Thank you for your question, sir. We're very concerned about the impact of deployment on veterans, male veterans, female veterans, anyone who's in a deployed situation. We know that deployment alone is not necessarily a risk factor. It depends upon what occurs during that deployment, the frequency of deployment. We have put into place special programs for units that we know had particularly difficult deployments. We're working with our partners to create reunion events for them and bring them back together. We know that the power of peer support and veteran-to-veteran support is critically important. We're looking for ways to extend that beyond the military life cycle itself into the veteran experience, making sure that all providers are aware of the impact of deployment, in making sure that community providers are also educated about the risks that veterans may have if they are seeing a community provider instead of one of ours. So, Dr. Hayes?
Thank you. I just want to bring up a couple of things, and I'm very grateful to the veterans who've actually done a number of works published about this, as well as the disabled American veterans within their journey home, working on the issues for women veterans. I think that there's a sense that for many women, they've had to come home and deal with the family and children issues, sort of postponing some of their own needs as they've dealt with this. And also, that's one issue, and it's the psychological family needs, family therapy, things like that the vet centers can offer, but women sometimes postpone those needs and then get a little bit lost to our systems. And some of the other challenges actually really are in the area of employment. And women have more difficult times getting into the right kind of employment and the levels of employment for any number of reasons. But these are areas that then are very impactful on their lives and, concern us in the transition, and particularly about the issues of self-harm and the risks during the transition time.
Ma'am, did you have anything else in that regard?
Not at all. But it struck me when you asked the question, going back to Ms. Chairwoman Brownlee's comment, the impact. I mean, it's kind of connected all the dots to me about the impact on our providers and our staff that meet these women veterans, especially, whether at any point of care.
Yeah. So just lastly, I haven't heard much spoken about, and maybe I might have missed this, but care management programs, and particularly efforts to meet patients or future potential patients, veterans, where they are. Calls, text messages, knocking on their doors. This is the future of healthcare, and it's particularly important for the veteran population, because many of them are not seeking care. They're certainly not seeking care at the VA, and sometimes we, based off our current system, don't want them to. So where do we stand on this, and what do you think we should be doing?
I think a really important part of this is the Women Veteran Call Center, which actually was set up to do outgoing calls to women veterans who don't use VA services, may not be connected, and to inform veterans about eligibility, appointments, cemetery, VBA. And we've touched 1.6 million women through the outgoing call center. The other part of the call center is obviously all the incoming calls, and we want to make sure that calls and texts are available. That's a primary triaging and information service that we find very valuable to women. The other is care management in terms of local care management, and we've expanded the number of women's care managers, particularly in the rural areas, and that's another part of our ongoing effort right now to beef up that program, to hire more women's care managers to do exactly what you're talking about, hook up with the veterans when they're in our clinics or in our facilities.
Is there any further improvements you think we should be making to the care management program? Is it adequately resourced right now?
I think the resources are there within VA. I think we need to right-size it so that we have the right kinds of services available.
What would that
to
look
women.
like?
It means moving people, making sure we have more care managers. It means even more devotion to this hiring of primary care providers, social workers, nurses. It's taking the resources we have and putting a greater focus on the Women Veteran Program within our own system.
Okay, thank you.
Thank you, Mr. Rose. I now recognize Mr. Barr for 5 minutes.
Thank you, Madam Chairwoman. Thanks for holding this hearing. Thank you for our panel for discussing the legislative proposals before us. And first and foremost, let me echo the sentiments of those expressed today in memory of those who sacrificed for our country. Of course, the 3,000 Americans who lost their lives in the attacks in 9/11, and also the thousands of servicemen and women who were inspired to defend our country in the aftermath of that great tragedy. So many of these post-9/11 veterans now deserve, and they have earned the support of this Congress and the Department of Veterans Affairs, and we appreciate all of your service in support of those heroes. Dr. Boyd, let me ask you a little bit about this Long-Term Care Veterans Choice Act, which I've been proud to co-sponsor. I want to thank, first of all, my colleague, Representative Higgins, for introducing this legislation. I like this bill because it gives our veterans who need long-term care freedom and flexibility. They may not always want to go to a traditional institutional nursing home, and when we think of the post-9/11 generation, these are young veterans, and especially if they're disabled, they don't want to go to what they consider a nursing home. So this is a really good alternative, I think. Allowing those veterans to live in a more intimate setting like a medical foster home makes sense for the well-being of the veteran and can be facilitated at a fraction of the cost. And I noted, Dr. Boyd, your comment about the net savings estimate. So it's a win-win, win for the taxpayer, win for the veteran, and I really think this is a great opportunity. The Lexington VA in my own district is proud to have a medical foster home program, and a former medical director had this to say about the program, quote, "The decision to leave the privacy and familiarity of your own home to live in a strange and unfamiliar environment is one of life's most difficult to make. Our program gives veterans a palatable middle option. Veterans live in the warmth and comfort of a medical foster home of their choice, and this is an encouraging option for our younger veterans injured in Iraq and Afghanistan who are too disabled to live alone, but they are too young to live in a nursing home." Dr. Boyd, in your testimony you state that only 200 of the 1,000 veterans living in MFHs currently would be eligible to be paid for by the VA under this program. Can you explain why that is?
That's taken into account that they are Priority 1A veterans. But don't let this deter from this at all. We easily have capacity to accommodate up to the 900, average daily per year of veterans that would meet that criteria. This is as you said, a win-win. First of all, the quality and respecting the wishes and the preferences of our aging or our needed are a needy population. So it goes long in line. I visited with Ms. Chairman Brownlee in a field hearing once where we talked about the Choose Home initiatives and long-term care and this coming up, and this is perfect. We strongly support this, this bill.
Thank you, and I noted your technical suggestions as well. You mentioned the one-year timeline that the bill gives you to get all the contracts in place. Would this work like the Mission Act's Community Care Network? Optum is Region 2 in my area. They're going to take over for Tri-West, for example. Would they get the contract for Lexington, for the Lexington area if they're already operating in our region for community care? How will that work?
So the medical foster home is separate and is a separate entity. I'm not aware of this being part of our CCN,
Community
our
care,
community
okay.
care. No, these are within the community. Yes,
So it would
Not
not.
to use the community
part of the
differently.
VA, not in the community care network.
That's correct.
Okay. MST, really quickly. Can any of you all think of potential barriers to care that exist for MST survivors seeking care? And I want to ask that question in the context of the Mission Act. Of course, eligibility criteria is whether or not it's in the veteran's best medical interest to qualify to seek care in the community. If an MST survivor were more comfortable with a provider in the community than at the VA, how would they interact with the community care criteria?
We screen all veterans for military sexual trauma that come into VA care, so it is a priority of focus for us. In terms of, and they can receive care at VA at no cost, and we make sure that staff can refer people to our military sexual trauma coordinators across our facilities. And we would work with, if they are more comfortable in the community, we would want them to go to the most appropriate resource to take care of them.
Well, I appreciate that. I think the VA is improving rapidly in addressing MST, and I know there's legislation here today that we're considering that addresses that as well for the VA. But a number of my, especially female veterans who I represent, are very interested in accessing community care for that specific issue. So we appreciate that, and my time has expired, and I yield back.
Thank you, Mr. Barr, and I just want to say I concur with your support on Mr. Higgins' bill. I think it's a great bill, and hopefully we can move that forward. So, Mr. Cisneros, you are now recognized for 5 minutes.
Thank you, Madam Chair. Thank you, everyone on the panel, for being here today. I want to address a couple things. Dr. Boyd, it's already been said, I think like over 75% of women don't use the VA. You know, it takes them almost 3 years before they are connected to VA, if they do. I mean, do you acknowledge that that is true?
I would defer that overall to Dr. Hayes from her expertise.
Yeah, those are accurate statistics. If there's a delay in seeking care, and what I would say, though, is we've gone up from where only 11% of women used our care when I was first working on this, and now we're up to 25%, but we're still way below the percentage of men who use VA.
Correct. We still have a long way to go. I mean, it's good that there's improvement, but still a long way to go. We'll acknowledge that. But, you know, on bills like 2982, where you oppose some research being done to find what are the barriers for women using VA care, and also in Section 4 of 3867, the VA thinks that a task force that would help women will find out why expanded services are available to veterans at risk of pertaining domestic violence, why that is necessary. I mean, you both reference, or you reference in your opening statement, that both with the one in 3867, that there was a study done, or a task force created back in 2012 and 2013, and this doesn't need to be done again. And then also in 2982, you talk about a study that was done in 2015 to done the barriers, to find out what are the barriers that keep women from seeking care. So if these studies have already been done, obviously, I mean, we both acknowledge, or everyone acknowledges, that more needs to be done. Why would we not seek, you know, more data, more information? Why would we not want to do a task force that would provide us with the information to find out how women could find out more information, or really to seek in regards to domestic violence? Why won't the VA acknowledge that we need to find more data and to do these studies and to do these task force.
Well, I'll start off with this. With regards to the Violence Against Women Veterans Act that you referenced, I will pass that off to Dr. Carroll in just a bit. But we have, in thanking Congress for the $17 million back in FY18 and 19, we have a very, very strong assistance program for the Intimate Partner Violence Assistance Program. We would suggest that that be the lead to take this forward. We already have that in place, and I would like, if it's okay, I'd like Dr. Carroll just to give a little snippet about that as well.
Yeah, it's an important area, and we know that intimate partner violence is also a risk factor for suicide, and so those two things, and being a woman, the combination of factors is a great concern for us. With the help of Congress, as Dr. Boyd mentioned, we did stand up the Intimate Partner Violence Assistance Program. There is a point of contact at every facility. We know that based upon evidence that if providers, ask about this and veterans feel comfortable talking about it with their provider, that there's a significant chance, a significantly greater chance that they're going to get out of a dangerous situation and take action against that. And so I think we have many things in place already. We're very happy to move forward with it and to learn more from our experience and to learn from women veterans as they participate in that.
Your last task force was 6 years ago. There's still obviously barriers for women to seek out these services. Don't you think it's time to update and to kind of maybe get a new task force together to find out what can we do more to increase these numbers?
If I could, we're sort of bifurcating two different topics. One is about domestic violence, interpersonal violence, and sexual assault. The other part is the survey that you have recommended we do. Again, I want to show you, this is the 2015 survey. It's no small report. It didn't, we took this, we've made recommendations, we have initiated actions. We have those actions moving forward. We have them going on. In addition, we've continued to talk to veterans in a very critical way through something that's called the Veteran Experience Journey. We have been working individually with veterans in various parts of the country to have them describe what they need right now today, and those experiences are being acted on. So we have pain points for veterans, like getting into the system, finding out about their benefits, getting better relationships with their providers, things that we would survey, but a survey just gives the answers across the country. It doesn't get us to the action. We've gone more directly to veterans right now in real time, and then we've have design factors that are making them happen. So we can explain more to you about what that is, but frankly, the amount of money that it takes to do a study like this, I have a sense that we're going to find the same answers that we know about right now from the veterans. They have difficulty with information, how to access, distance, understanding the Mission Act, all these things that we can work on today.
My time's expired, and the size of the report doesn't really suggest that it's better, but maybe we need to start asking different questions so we can get these numbers up. We need to figure out how we can get women to start using the VA benefits and to really seek treatment at the VA that they're entitled to. And I'm glad that you're up to 25% now, but that's still way below where it needs to be. So thank you very much for your time.
Thank you, Mr. Cisneros. Mr. Levin, you're just under the wire. You're now recognized for 5 minutes.
Thank you, Chair Brownlee. As a member of the Women Veterans Task Force, I appreciate you holding this hearing on a number of bills addressing women veterans' health care needs. It's critical that we tailor VA services to women veterans rather than asking them to just adjust to a male-centric system. One of the ways we can do this is by training our providers at VA and those we partner with in the community to better understand the unique needs of women veterans. I want to thank my colleague, Mr. Rose, for introducing the Breaking Barriers for Women Veterans Act to work towards this important goal. Dr. Boyd, I'd like to ask you about your testimony on this bill. You mentioned that some clinics do not treat enough women to justify a full-time women's health care provider and instead train existing providers to treat both men and women. Who trains these providers, and how does the training specifically address the needs of women veterans?
Well, I will pass that off to Dr. Hayes. She can give you a much more fluid answer. We're very confident in that training. So, Dr. Hayes.
We have an extensive training program. The basis, it starts with the Women's Health Mini Residency, where the providers go for a week. They train with what's called standardized patients to do pelvic exams. They also learn about deployment issues. They work with chronic pain. They learn about contraception and abnormal pregnancies, everything that they need to have their skills updated on. This year, we trained over 700. We have trained over, it is our own staff that trains. And some of it's a train-the-trainer model, but it is our own highly proficient women's health providers that do the training.
Thank you, Dr. Hayes. Dr. Boyd, you also stated that the $1 million increase for the Women Veterans Healthcare Mini Residency Program would be unnecessary, but also stated that past mini residencies have had waiting lists because demand exceeds capacity. If this is the case, can you explain why VA does not support a funding increase?
This is, if I may, this is a technical issue. In the bill, we were unclear whether this 1 million, first of all, whether that's a ceiling and would actually crimp our style. I actually spend about $1 million right now. It's the staff capacity to go on and do more training that has left us with this problem of having people still on the waiting list. We've done a number of initiatives to work on that. One is our Rural Health Initiative. We've started a new team and have people go out to the rural sites where our greatest need is and train them on site. So that's one of the things that we're doing. But we've just sort of reached the max of what we could do right now, and that's why we have waiting lists. We could expand it. We think that VA has within its resources to do this. It's always great to get additional appropriations, but we were concerned that you not limit us to $1 million because
Okay.
we're already spending that
So
level.
it sounds like there's an opportunity for some collaboration between yourselves and staff to work out that language to clarify.
I'd welcome that. Thank you.
That's good. Dr. Boyd, I'm glad also that another one of the bills we're reviewing today, the VA Hiring Enhancement Act, would provide additional tools to recruit staff. I hear from many veterans in my district in Southern California that understaffing affects their ability to receive health care in a timely manner. And as you noted in your testimony, the provision allowing VA to recruit physicians before they complete their residencies only applies to those that enter a specialty field. Could you explain why this authority is important in the recruitment of both primary and specialty care providers?
So a couple of things. In addition to the hiring authority that we have, we can offer a job, if we have a slot available, to a training resident within any facility, within my facility, say. But they have to meet the requirements by the time of employment. And that's part of what we want to do. We want to hire the ones that we train. They're there because they like the community, they're invested, and just to be clear as well, we have been afforded other hiring authorities and opportunities from Congress as well. The education debt reduction is huge. That has been a huge success for us, as well as our retention and our incentives and relocation. So we can hire ahead of time, and that's the best thing to do. If you see a good candidate who's in training, we want to hire them. So we already have that authority. We don't think that that in fact would be a duplicative authority for us. And next week, I don't know if you were here earlier, but next week there will be a hearing, and there will be specialists in that workforce area and HR area that we have been consulting with.
Thank you.
You're
And
welcome.
I'm out of time, but I want to again commend the chair for her great work on the Women Veterans Task Force and all of my colleagues on both sides of the aisle for all their excellent work in service of our veterans. Thank you very much.
Thank you, Mr. Levin, and I don't see Mr. Stubbe. He was here earlier. And so I will just say, before I excuse the panel, that Dr. Boyd, thank you for a pretty comprehensive written statement. I think that you've made some valid observations with some of these bills. There are some places where we may not agree completely, but I hope that over time we can work through these things and to see these bills through and sent to the President's desk for signature. So we will look forward to that work ahead of us. And having said that, thank you for being here, and we will excuse you, and we will move on to our second panel.
Thank you very much.
welcome to our second panel. Thank you for being here. We have Mr. Jeremy Butler, Chief Executive Officer for Iraq and Afghanistan Veterans of America. Next, we have Ms. Joy Elam, National Legislative Director of Disabled American Veterans. And finally, we are also joined by Mr. Roscoe Butler, Associate Legislative Director for Paralyzed Veterans of America. Thank you again for being here, and I now recognize Mr. Butler for 5 minutes.
Thank you, ma'am. Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee, on behalf of IAVA, thank you for the opportunity to share our views on the pending legislation today. I would like to take a moment to say that I also appreciate the opportunity to testify today on the anniversary of the September 11th attacks. It was obviously a tragic day in our country's history, but it was also a day that inspired many of IAVA's members to join the military. And it's an honor to be here with you all to work together to ensure that we're getting them the best care that our veterans deserve. Support and recognition of women veterans is an incredibly important part of IAVA's work, and as such, it's included in our 2019 Big Six priorities. We launched our groundbreaking She Who Borne the Battle campaign in 2017, focused on recognizing the service of women veterans and closing gaps in care provided by VA. IAVA chose to lead on this issue not only because it is important to the nearly 20% of our members who are women, but because it is important to our entire membership, and it will help ensure the future of America's health care and national security. 2 years ago, IAVA worked with congressional allies to introduce the bipartisan Deborah Sampson Act in the House and the Senate. It called on the VA to modernize facilities to fit the needs of a changing veteran population, increase newborn care, establish new legal services for women veterans, eliminate barriers faced by women seeking care, and increase data tracking and reporting to ensure that women veterans get care on par with their male counterparts. The Deborah Sampson Act was not passed last session, but IAVA recognized that some progress was made in support of women veterans, with key provisions of that legislation passed or funded. With much more still to be done, though, IAVA strongly supports passage of all of the provisions of the Deborah Sampson Act. Many have been introduced by members of this subcommittee and across Congress, and IAVA emphatically supports the 6 Deborah Sampson Act bills being considered today: H.R. 2645, 2681, 2798, 2972, 3036, and 3636. IAVA also supports the VA Newborn Emergency Treatment Act. Coupled with provisions in the Deborah Sampson Act, this will finally allow VA to adequately care for veteran mothers and their babies. To design precise policy solutions, we also need robust data collection, sharing, and analysis to know the extent to which women veterans are underserved. IAVA strongly supports 3 bills to address these shortcomings: the Improving Oversight of Women Veterans Care Act, the Women's Veteran Health Care Accountability Act, and Improving Benefits for Underserved Veterans Act. For women veterans who choose to seek care at VA, finding quality providers who understand their needs can be difficult. Not surprisingly, women veterans are more likely than their male counterparts to seek care in the community, meaning they are often seen by private care providers that may not understand military service and its health impacts. Our 2019 member survey found that while 70% of respondents felt that VA clinicians understood the medical needs of veterans, only 44% felt that non-VA clinicians understood them. For these reasons, IAVA supports the Women Veterans Equal Access to Quality Care Act and the draft legislation to establish the VA Office of Women's Health. Since 2001, the number of women using VA services has tripled. As more military women make the transition to civilian life, it is paramount that DoD and VA are ready to support them. That includes ensuring proper reproductive care for women veterans and their spouses. Currently, women veterans do not have the same access to contraceptives as their civilian counterparts. That is unacceptable, and it is why IAVA supports the Equal Access to Contraception for Veterans Act. Ensuring that the VA is able to accommodate the millions of veterans who use it for access to medical care and benefits is paramount to ensuring the lasting success and health of the veteran population. About 48% of all veterans and about 55% of post-9/11 veterans are enrolled in VA care. IAVA's members, among our survey respondents, 81% are enrolled in VA health care, and the vast majority have sought care from VA in the last year. The VA has made incredible strides in modernizing its operating systems, but VA also needs robust, modern hiring practices in order to compete for talent to fill their overwhelming number of vacancies. To this end, IAVA supports the VA Hiring Enhancement Act. Members of the subcommittee, thank you for your commitment to ensuring women veterans receive care that is on par with their male counterparts, and thank you for the opportunity to share IAVA's views on these issues. I look forward to answering any questions you have.
Thank you, Mr. Butler, and I now recognize Ms. Elam for 5 minutes.
Thank you, Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee. DAV appreciates the opportunity to provide testimony on the 17 bills under consideration today. We thank the subcommittee for its focus on improving VA healthcare services and programs for our nation's women veterans. Ensuring women have equal access to high-quality, comprehensive primary care and the specialized services VA offers is a critical legislative priority for DAV. We're pleased that many of the bills we are providing comments on today reflect recommendations made in DAV's 2018 report, Women Veterans, The Journey Ahead, and comport with DAV Resolution Number 020. DAV offers our support for H.R. 2645 and H.R. 2752. These bills improve VA's maternity care package and ensure VA can secure appropriate contracts for VA-sponsored community care for women veterans and their newborns. H.R. 2681 requires VA to submit a report on the availability of prosthetic items for women veterans in VA. While DAV supports the intent of this bill under DAV Resolution Number 383, we ask the subcommittee to consider broadening the scope of the study proposed to ensure the intent of the legislation is fully realized. Specifically, we want to ensure that women veterans have access to high-quality prosthetic items and prosthesis that meet their expectations in fit, function, and appearance. DAV is also pleased to support H.R. 2798, a bill that would establish a permanent counseling program in retreat settings. This pilot has shown consistent improvements in participants' ability to better manage PTSD symptoms and maintain learned coping strategies. It also garners high satisfaction rates among women who note peer interaction and networking is especially helpful for long-term recovery from post-deployment mental health challenges that many women veterans face. DAV supports H.R. 2972, 2982, and H.R. 3036, bills which focus on improving web-based resources and outreach to women veterans, information about availability of women's health services throughout the VA system, correcting environmental care and staffing deficiencies for women's health, and eliminating barriers to care. H.R. 3224 seeks to ensure women veterans have access to comprehensive gender-specific care in all VA facilities and calls for a study on using extended care hours to better serve veteran patients. While DAV supports what we believe to be the overall intent of this bill, we do ask that the definition of gender-specific services be added to the bill prior to its advancement. In our formal statement, we express concern that without that definition, there could be an expectation that services such as obstetrics and newborn care, which are generally provided in the community, would be required in VA facilities. H.R. 3636 and H.R. 496 call for comprehensive reports that include data on the women veteran population using VA, models of care, access to care in the community, capital investment planning, environment of care standards, and staffing levels and provider training in women's health. DAV believes the collection and summary of this data in one report can be helpful for future planning to better meet the needs of this growing population, and we're happy to provide our support for these bills as well. DAV also supports H.R. 3798, a bill that would eliminate co-payments for contraceptive items and medication in accordance with DAV Resolution Number 365. H.R. 3867 seeks to create a national task force to integrate VA programs with existing community resources to better serve veterans who've experienced sexual assault and domestic violence. DAV does not have a specific resolution calling for such a task force or plan. However, we acknowledge the impact of these issues have on many veterans and have no objection to a passage of this bill. The final draft bill, Women Veterans Bill, being considered today, would establish an Office of Women's Health within the VA. This measure would provide the director of the office control over all aspects of women veterans' health care, including distribution of resources. DAV believes this change is warranted and necessary for VA to address many longstanding issues and the enhancement of the provision of care for women veterans using VA, and therefore supports the bill's passage. Finally, DAV supports the remaining bills on the agenda mentioned here today, H.R. 1163, the VA Hiring Enhancement Act, H.R. 1527, the Long-Term Care Veterans Choice Act, H.R. 2628, the Vets Care Center Act, and 2816, the Vietnam-era Veterans Hepatitis C Enhancement Act. Chairman Brownlee, that completes my testimony, and I'm happy to answer any questions the subcommittee may have.
Thank you, Ms. Elam, and I now recognize Mr. Butler for 5 minutes.
Thank you, Chairman.
Mr. Roscoe Butler.
Thank you, Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee. Paralyzed Veterans of America would like to thank you for the opportunity to submit our views on the important legislation pending before the committee. The bills being reviewed today address a number of challenges veterans are facing and will provide vital assistance to help them overcome the pain and suffering from domestic violence while improving oversight of women veterans' health care and breaking down barriers for women veterans. For the sake of time, and since you have my full written statement, I would only discuss a few of the bills. H.R. 1163. PVA encourages many efforts to bolster staffing levels at VA facilities, particularly within the spinal cord injury system of care, which historically data shows is one of the most difficult areas to recruit and retain physicians and nursing staff. We strongly support H.R. 1163, the VA Hiring Enhancement Act, which seeks to release physicians from non-compete agreements for the purpose of serving at VA. Removing these barriers would help encourage more of the best and brightest doctors and nurse practitioners coming out of medical school to pursue a career in the VA. H.R. 2982. PVA also supports H.R. 2982, which directs the Secretary of Veterans Affairs to conduct a study of the barriers for women veterans to health care from the Department of Veterans Affairs. A major concern for PVA members is the accessibility of facilities. Here are a few recent examples of the barriers PVA members have experienced. Women veterans having to sit in their wheelchairs outside a Model 3 Women Veterans Clinic because the facility did not have a system in place to alert staff that someone was waiting to gain access into the clinic. Poorly designed facilities that limit VA's ability to provide medical care to people with severe or catastrophic disabilities and not having the appropriate diagnostic equipment on site to conduct mammography examinations on spinal cord injury women veterans. Identifying these and other kinds of barriers that women veterans face is an important first step toward improving the care they receive from VA. H.R. 3224. Without additional clarification, PVA cannot support H.R. 3224 as written. We are concerned that H.R. 3224 does not define the type of gender-specific services VA is required to provide. VHA Directive 13300102, Healthcare Services for Women Veterans, break down gender-specific care into several categories: primary care and specialty care. Paragraph J provides a list of gender-specific specialty services that must be available in-house to the greatest extent possible. Unless additional clarification is provided, VA could interpret Congress' intent with this legislation as a requirement to offer gender-specific services in each VA medical center or community-based outpatient clinic. There are a number of gender-specific services, specialty services, listed in VA's directive that VA medical centers and community-based outpatient clinics are not capable of providing, particularly when it comes to maternity and newborn care. In order to improve the bill and earn our support, this legislation would have to include language clearly defining the kind of gender-specific services VA would be required to provide. Again, PVA appreciates this opportunity to express our views on some of the many important pieces of legislation being examined today, and I'm available to answer any questions.
Thank you, Mr. Butler, and I want to thank all of the witnesses today for your testimony, and even more importantly, thank you for your engagement on all of these very important bills. So I will now recognize myself for 5 minutes for questioning, and The first question I wanted to ask really is to Ms. Elam, since you referenced this, around my bill, the Office of Women's Health. So, you know, what I'm trying to get at here, basically, with the bill is, you know, when we're looking for equity and parity in terms of health services to women, you know, one quick thing one would look at is if women veterans make up 10% of the veteran population, and then you look at the healthcare budget, roughly you should see, you know, 10% of the resources being spent on women's health. That makes sense. Medical directors across the country have a lot of flexibility and authority in terms of how those resources are spent. And in some cases, they may spend way beyond 10% in their facility. In other cases, they won't. So, you know, the intent here is to try to provide some accountability and some oversight with regards to how resources are being spent. Because the reality, at the end of the day, all of these issues that we're raising comes down to money to be able to provide the services, the staffing that we need to properly address veterans' needs, and in this case, women's veterans' needs. So do you have any other ideas of how we go about that? Do you think this is headed in you mentioned that it was headed in the right direction, and I appreciate that, or if you had any other sort of ideas.
I think this proposal would be key to really addressing what the Congressional Task Force on Women Veterans is really seeking to do, which is to take care of these longstanding issues that have been around for some time. I mean, I can just remember testifying on many of these same issues for, you know, more than a decade now. I think the Women's Health Services Program Office in VA has the direction, has the data, has much of what they need. They just need to be able to execute it. And I don't see that they really had that authority at the level of where that office is now. I know in VA's testimony, they indicate that, you know, they feel it's positioned appropriately for them to carry out, but we would respectfully disagree. I think this will be key. They've got a plan, they just need to execute it, and if they have the support of the leadership and the secretary in VA to really address these problems and take care of the staffing issues, the deficiencies, the cultural issues that they want to address. They've noted all of these things, and they have a provision of services that they want to provide. So I hope that this bill will be considered and move forward, because I see it's key in overall work that you and the committee and the subcommittee are trying to do.
Great. Thank you very much. Do the Mr. Butlers have any comments?
I don't have anything to add.
Okay, very good. You know, and this question is really to anyone and all of you on the panel. You know, 3 of today's bills address improving reproductive health care access for women veterans. Can you add any additional services that the VA should be providing that would improve reproductive health for women?
I'm happy to jump in there. Yeah, I think a number of important issues are discussed in the legislation that's being discussed today. But beyond that, one of the recommendations that we have that IVA has in our policy agenda is around expanding access to and funding for in vitro fertilization. I think IVF is another one of those areas where you have a disconnect between services available to active duty service members and then what is available to veterans. And this is an especially important question for our membership, because we do have a younger cohort, many of whom have deferred parenthood, perhaps until their time in service was over, because those demands in service were so great. And so increasing these accesses to things around fertility and child care is very important to our membership.
Thank you. Mr. Butler?
I don't have anything additional to add, but I would like to bring to your attention the issue of mammography exams for women veterans in wheelchairs. VA facilities, most VA facilities, while they may have a mammography machine to do the exam, they don't have the appropriate equipment. So most of the time, women have to sit in their wheelchairs. If they're a large woman, it's difficult to raise. There are certain equipments that they can purchase that will make it much easier for them to do their exams. And if they complete the exam without the woman getting out of the wheelchair, it's not going to be the appropriate type of examination that really should be done. So I would ask that they really look at that and expand upon the type of equipment that they purchase and procure for women, particularly who are in wheelchairs.
Thank you for adding that and bringing that up. And I will say that you have an extraordinary representative who came to my office, woman in a wheelchair, talking about this issue, and she was quite persuasive. So thank you very, very much. And with that, I recognize Dr. Dunn for 5 minutes.
Thank you, Chairwoman Brownlee. I want to start with saying that we fully expect that some of the items that are coming through in these bills' agendas are like to have cost implications to the VA. And what we'd like to do is secure, the VSOs, all of them, you being lead dogs, as it were, on the VSOs, to work with us here in Congress and with the VA specifically that what we can do in our jurisdictions to get offsets for some of these costs, because hopefully we can find some of the money right there. Yeah, so please address that.
I'm happy to step in. I think we often caution about this discussion where the pay-fors come from other veteran benefits. I don't necessarily have the answer as to where the monies should come from, but what I can say is our membership is adamant that it should not come by reducing other benefits that go to veterans. We fought this battle just last year, I think it was, around the GI Bill, when there was an attempt to maybe make some cuts on the GI Bill payments to have some money go to another veteran's benefit. We always want to ensure that our veterans are getting the care that they deserve and the support that they deserve and the benefits that they deserve, but we should not be cannibalizing one program to fund another one, especially when both of those programs are equally necessary and important.
PVA echoes Jeremy's concerns and would not support taking away funding from one program to support another program. We have to find a common way to support all of the bills being presented today. And we, PVA, supported all of the bills today with one exception. So whatever the common ground that we can reach, but we echo Jeremy's concern.
I think my colleagues have addressed our same concerns, but certainly we want to be able to work with with you and your staff on this agenda, because we think it's so critical and so important. But we do have those considerations in mind when it comes to taking away from one veteran to serve another veteran, and we want to make sure that services that are being provided to women veterans we have equal access to care, which has been a problem.
So my thought was actually more about programs that are either no longer viable, or they're replaced with newer programs, or some programs are overfunded. There's extra money sitting in some parts of the VA, and I think we can all identify efficiencies in offices. Certainly, I did identify a lot of efficiencies in my offices over time. Next question, Ms. Ellen, I read your testimony. I liked it, but there was one jarring. I kind of kept coming back to it. You said you thought that let me get the paragraph here. We believe the VA Health has different responsibilities than the healthcare industry in general. I've worked in both VA and civilian healthcare and active duty healthcare. What do you think's different about it? I mean, other than you have a unique population.
Well, definitely, I think in that reference that was on Bill 1163, we were talking about the responsibility of VA to train, the training responsibility that they've had for training our nation's clinicians. So
So training, you think that's the unique part of it, that they have to do training?
Well, not just the training of clinicians, but that's been one of their major functions within the department.
I remember.
Yes, at most, so many clinicians are trained through VA, and they do have some additional responsibilities that, we don't see so much in the general sector, and a very specialized mission and some very specialized programs. So I think we're just trying to make the point that VA is a unique healthcare system in itself.
All right, so I thought I traveled pretty fluidly between the different programs, and it's about taking care of people. Certainly, I like taking care of military people especially, but that's why I did it for a long time. But I kind of kept coming back, like, what's different? What's different? All right. So last thing is I want to ask you to help, again, as advocates for services in the VA for the hepatitis C program. We talked earlier with the first panel, we've cured 100,000 veterans of hepatitis C. That's amazing. That's just amazing. When I was practicing, 20% of surgeons would terminate their career because they caught hepatitis from a patient during surgery. Accidental needle pricks. So this is a big, big deal. It's close to my heart. I want you to get the word out to the veterans. Thank you very much.
Thank you, Dr. Dunn. Mr. Lamb, you're recognized for 5 minutes.
Thank you, Madam Chairwoman, and thank you for holding this important hearing and advancing all these bills. We have a lot of work to do in this area, and I think those of us who served in uniform more recently know that there's just absolutely no excuse for any veteran, man or woman, feeling that when they leave the service, the VA services are not for them. And so I think we're starting to make a big impact on that now, but one of my concerns that we see across problems faced by the VA is difficulty in connecting with the people who we're intending these new services and reforms to reach. And so I'm sure you've addressed it a little bit already. I apologize for coming in late, but I just wanted to throw it open to any of the three of you about whether you can advise us on what we can do to better reach into the wider veteran population that is not enrolled in VA services or that are enrolled once and didn't like the experience and has never used it again, to advertise some of these new things that we're passing to invite people back in. And I guess kind of a subset of that, if you've had any experience with it already, is what are the implications for community care? Obviously, community care has been expanded. A lot of new services and new patients will be eligible for all of that. Are you seeing excitement or interest in community care among women veterans, particularly those maybe who haven't used the VA much before? Anyone who can weigh in on that?
Sure, I'd love to take the opportunity to talk about that. While we support community care and we want women veterans who feel they need access to care in the community or may need because VA can't provide certain services, obviously we want that to happen. We think it's really critical, though, during this implementation phase of the Mission Act, that VA is really instrumental in being the coordinator of that care as those women veterans go to the community. As you heard from the first panel today, so many women veterans have the women who are being seen in VA have complex medical health histories and challenges. Their veteran experience is really important, and VA can help train those providers that are going to be in their network to make sure if they're seeing a woman veteran, here are the things that we know about this woman veteran population and to be sensitive about, and the gender sensitivities and cultural sensitivities around military sexual trauma, especially. So I think that's going to be critical, and for VA to be a real partner, because we know some women veterans have had a really negative experience in VA. But at VA, we do want them to reach out. So many changes have been made just over the past 10 years. We've seen incredible changes. I'm a woman veteran. I use VA. I have for 20 plus years. I've seen those changes firsthand, and I think they would really benefit for coming to VA, especially those who have service-connected disabilities, obviously those who have catastrophic injuries, our OEF, OAF population, so key. They've had several deployments, and over time, there's really so many benefits in VA with their specialized programs. So I hope that VA will be able to do some additional outreach to those. Come back, try the VA, we're there for you, and improve services.
I think that's an excellent point. Mr. Butler, did you want?
Yeah, I was just going to echo Joy's statements about Mission Act and community care, and then just add maybe around your question on getting word out and everything. Yeah, I was in a similar case. When I transitioned off active duty in 2005, I didn't really understand the VA. It wasn't really something that was talked about when you're on active duty. I think once you start to hear about it when you're out of active duty, you generally hear the more negative things rather than the positive things. So I think as VA care continues to improve and there are more positive stories coming out, one, I think you're going to have a more understood idea in the veteran community that it is a positive place to go. But then there also just needs to be better interaction, I think, with the nonprofit organizations, with community care organizations to understand how to access the VA. I've been in this business for 4 years now, and it still is incredibly complex to me to understand how one accesses the VA to begin with.
No, it is, and that seems to be the most important hurdle. What I always hear, at least, is that once people finally get enrolled and are in, and they know that they're in, at least in Western Pennsylvania, they're happy. They think the VAs are great. But we have a hard time getting people over that initial obstacle. So I think that's what we can all work on, and I think your groups play a really important role in that. So please continue to challenge us as to how we can support you to recruit new people and get better information to those that are there. And with that, Madam Chairwoman, I yield back.
Thank you, Mr. Lamb. Mr. Barr, you're recognized.
Thank you again, Madam Chairwoman, for holding this hearing, and thank you for considering legislation that supports and recognizes our women veterans and newborns and their kids, and looking at ways to eliminate barriers for women veterans to access the VA. I would note, Chairwoman Brownlee, that I was happy to support your bill, H.R. 840, earlier in this Congress. The Veterans Access to Child Care Act is one of those barriers is needing to provide women veterans with child care so that they can have the time to go seek veterans care. I would urge you and Chairman Takano to consider the VA Child Care Protection Act, which we offered as a motion to recommit, and then we also offered as an amendment in the last markup to the Cisneros bill. And then in July, we introduced a separate bill because I think there was some commentary that it needed to be separate from the Cisneros bill, the VA Child Care Protection Act, to make sure that employees of the VA are not a threat to our children, so that wouldn't be an additional barrier for women veterans seeking access to care. And just to remind the committee, we did send a letter on July 19th with 10 Republican members of this committee to the chairman asking for a hearing. We have not yet heard a response. I just bring that to your attention, Chairwoman Brownlee, because we would like to work with you on that issue. Mr. Butler, in your testimony, you point out that while the VA provides care team support to the medical foster homes, it does not have the authority to pay for the cost of those medical foster homes. As a result, veterans must use personal or other funding sources should they choose this alternative rather than nursing homes. And I appreciate your association's support and endorsement of the Long-Term Care Veterans Choice Act to support more of your members having access to these MFHs. Can you or any of the other colleagues on the panel describe what funding sources veterans do use to pay for this care, and obviously the hardship that creates?
I can't necessarily speak specifically to that, but what I do know is that financial hardships are one of the main reasons that veterans come to our organization seeking support, and a lot of those financial hardship cases are underpinned by trying to pay for medical care that they need. We have a rapid response referral program that veterans and family members can reach out and work with social service professionals that are employed by IAVA, and this is one of the most frequent things that they hear about. It's financial hardship, and then when they start to dig into what the cause of the financial hardship, it's paying for medical care. So that's kind of a high-level answer to your question. It's not exactly specific.
Can you speak to the quality difference or the quality of life differences that veterans may experience, those who live in these medical foster homes versus traditional nursing homes? Any of your members of any organizations can speak to that?
We just have heard that, and I think some members on the committee today have mentioned, especially for younger veterans who maybe have experienced a TBI, can't live independently, but could really benefit from living in a medical foster home environment versus a long-term, perhaps nursing home, one of the community living centers. So I think it really adds to their dignity, to their quality of life, what they want to achieve, even though they've undergone, a serious injury or disability. So I think the medical foster home is just an excellent program. We really hope that we can make sure there's no disincentive for any service-disabled veteran to choose that access or that option.
And I'll just add, it adds to their independence, being able to live outside of a nursing home facility. And then overall, as Ms. Elam mentioned, their quality of life dramatically improves in living in a medical foster home versus being in a
Thank you,
community
Mr.
nursing
Butler.
home.
And Ms. Ilam, one last question for you. With regard to your testimony on H.R. 3867, the Violence Against Women Veterans Act, I was interested in your testimony that there was a study that women are re-traumatized when they're attempting to obtain care in the VA, and that those occurrences are all too common. Are we seeing the setup of nationwide community care under Mission Act in a way that would get women veterans or men veterans who are uncomfortable in the VA because of being re-traumatized? Are we seeing the Mission Act give an alternative to those veterans who don't feel comfortable in a VA and want to choose community care to deal with MST?
Well, VA's recent harassment study, I think, is just really alarming for a lot of us. We know that some women veterans coming to VA have reporting being harassed while seeking care, and that's been a disincentive for them to go. And these are generally probably the ones who most need that care. So I think here in the community, for some women veterans, may be the answer, but I hope that that's a temporary thing. I really hope VA, which they've talked about today, that they're addressing these issues full force, full on. Their culture has to change, making sure that every veteran feels welcome at VA, and obviously no veteran should be harassed, male or female, coming to VA. And we don't want that to remain. I mean, we know that's a problem, and I grant it to VA for actually bringing that research forward, and we've been hearing that for some time. And, if that's prohibiting somebody from going, we want them to get care, then that might be something that they could consider in the community. But we certainly don't want that to just be the only place they can go. We want it to be fixed within VA.
Yeah, absolutely. Thank you, and I yield back.
Thank you, Mr. Barr. You can never say I never gave you extra time. So, Mr. Bilirakis, you're recognized for 5 minutes.
Thank you, Madam Chair. I appreciate it very much. This is my questioning will be regarding H.R. 2628, the Vet Care Act, which I introduced. The VA has expressed concerns. This is for the entire panel. We'll start with whoever wants to go first. The VA has expressed concerns about apparent disparities created in H.R. 2628, the Vet Care Act, pilot programs, eligibility standards. Given the logic of the VA, it seems to me that every pilot program VA's ever operated could also be viewed as creating disparities in care for veterans. Indeed, this argument could be applied across the board to all valid, controlled clinical research done in science and in medicine. There will always be limitations and exclusions. Considering the current eligibility criteria for dental care in the first place, can you explain why you agree that this pilot program is a reasonable way to take a first step into assessing the specific benefits of preventive dental medicine at VA, such as the one in H.R. 2628? Whoever would like to go first, please.
I'll try and address it, but as we said in our written testimony, Oral health has a major impact on their physical health, and gum disease is often associated with diabetes, heart disease, and many other serious medical conditions. So a large number of veterans who receive care from the VA are not getting the appropriate dental care needed, and which could later add to other complications of health complications.
Thank you. Anyone else, please?
DAV's been a long-time advocate of dental care for all veterans, it being within a comprehensive care package. As we know, anybody who has health insurance, I mean, dental insurance is an important part of that complete package of care, and we've long wanted to make sure that veterans have access to that. So I think your bill is very reasonable in terms of a start to look at the conditions, as Mr. Butler indicated, that are prevalent in the veteran population, and to kind of mirror this study and as a first step of really offering that benefit.
Anyone else?
Just to agree, I've never understood the disconnect between dental care and medical care. I think, we've all, I think, are in agreement here that it's the whole health that is the important part here, and these should be seen as one thing, so we're very much in agreement.
Thank you very much. And I want to reemphasize that Dr. Jeff Coate from the University of Pennsylvania, who is the former dean of the dental school there, actually helped me craft this bill. And she actually conducted the study, and I worked with a dentist in my community as well, Dr. Zach Calarico, who is a good friend. But let me go ahead and ask one more question. The VA has expressed some concerns that the pilot in the vet care program would lead to veteran dissatisfaction if the pilot disqualifies certain veterans who receive examinations for dental care and are deemed to need surgery. H.R. 2621, however, specifically authorizes the VA to provide administrative support to ensure those veterans can receive the treatment that they may need. My thought is that the patient is better off than before because they have been alerted to a treatable problem, having received a free examination compared to previously, which must be seen as a significant benefit to the veteran with diabetes. To the panel, do you think your members would be dissatisfied with the pilot program outlined in this bill, especially considering the end goal? And we know what the end goal is, and I appreciate the chairwoman working with me on this particular issue, because we all want veterans who qualify for health care under the VA ultimately to get dental care. So whoever would like to go first, please respond to that.
I think veterans would understand your explanation, and certainly sometimes just even having that first opportunity to really identify, I have a problem and there's an issue here, and hopefully the assistance to get that care, that they wouldn't be dissatisfied. They may want to make, they would love to be able to have that access to a full treatment, but I think it is a first good step, and it's something. So certainly we'd be supportive of that, and I think most veterans would agree with your logic.
Thank you.
I agree with Ms. Elam, and an informed veteran is a happy veteran to the most part, knowing that they have a condition that they didn't know they had, and then what's the recourse for taking care of that condition then becomes the issue for the veteran if they can't get it in the VA. But not knowing you have a condition is really not a good thing, which could lead to other complications.
Yep, agreed. I'm still in the Navy Reserves, and I have to get a dental checkup from a Navy dentist every couple of years, and it simply is to make sure that you have a proper level of dental care. If they find something wrong with you, the Navy, the Department of Defense isn't going to pay to cover it for you. They alert you that you need to go out and get that taken care of on the private side. If that's the way we're handling our reservists, and I think veterans would understand that it's the same thing, that you're getting access to a determination that you need some support, and then you can go from there. So I think they would be okay with it and understand.
Yeah, and under the legislation, we authorize, after the pilot program, the caregiver, the dentist will refer them possibly to a nonprofit or the insurance program. And that'll be very helpful as well. But I think it's dangerous not to get the examination. So thank you very much, Madam Chair. I appreciate it. I'll yield back. I guess I'm over time. I apologize.
Yes, you too can never say that you've never had extra time on this committee. So, well, this concludes our questioning, and you know, before I close, I wanted to just thank the VA staff for staying through the second panel. That doesn't happen every time when the VA comes to our hearing, so we appreciate that very, very much. And I think I just want to conclude with just a few remarks, and to say first that we have, I think this has been a good hearing. I'm very excited about these proposed bills. But first, we have a long way to go until we uphold the promise that we've made to our veterans, and this includes achieving equity for our women veterans. And second, the VA must plan ahead for rapid growth of the women's veteran population. And I think many of these bills sort of address that. And the bills discussed today gives a VA the tools to identify gaps and opportunities to plan for that growth and allocate resources accordingly. So again, before I conclude, I just want to reemphasize my hope for this subcommittee, and that we continue to work in a bipartisan manner. I look forward to continue to work closely with Ranking Member Dunn, as we have already done and will continue to do, and bipartisanship in this committee. That's the only way we're going to get to good results for our veterans. So I thank all of our witnesses for their expertise and my colleagues for their interest. And with that, Dr. Dunn, would you like to make any closing comments?
Thank you very much, Chairwoman Brownlee. I just want to say thank you as well to both panels. I think you know, it has been a good exchange. I think you see the interest level in Veterans Affairs, you know, throughout the Congress and the administration. It's reflected in the budget as well. I would. VA continues to be the single largest source of my constituent services problems. I guess the people come, they run afoul of the system. So anything we can do to help that system. You know, we're doing it on a one-by-one basis back home, but you guys can do the whole thing at once. So we appreciate everything that you can do up here and helping us with that. And I agree. Working with Ms. Brownlee on a bipartisan basis, we should be able to get something accomplished. In the last session, it was the single most productive committee, I believe. Was it? Yeah. The VA committee was the single most productive bill-wise committee in the Congress, in the last session of Congress. Let's see if we can do that again. Thank you.
Hear, hear. So with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, the subcommittee stands adjourned.